Hi friends, I am Dr. B.V. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.in and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and for reference to medicals. Today I am going to discuss about the femoral hernia. Femoral hernia is the less common type and comes in third position. Femoral hernia is more in women than in men. Femoral hernia is more liable to be strangulated and can't be controlled by truss. The femoral canal occupies the most medial compartment of the femoral sheath and looks like a truncated cone. Femoral canal extends from the femoral ring above to the saphenous opening below. It is half-inch long and half-inch broad at its base and is directed upwards. Femoral canal contains fat, lymphatic vessels and the lymph node of Cloquet. Femoral canal is closed above by the septum of Cruret, a condensation of extraperitoneal tissue pierced by lymphatic vessels and below by the cribriform fascia. The femoral ring is bounded anteriorly by the inguinal ligament, posteriorly by Astley-Cooper's ligament, otherwise called iliopectineal ligament, the pubic bone and the fascia over the pectineus muscle. Medially by the concave knife-like edge of Gimbernat's ligament or lacunar ligament. Laterally by the thin septum separating it from the femoral vein. For the repair of femoral hernia, on lateral side the femoral vein and the internal saphenous vein must be protected. On the medial side of the neck of the sac, care must be taken to save bladder as a portion of the bladder forms part of the wall of the sac. Hernia passing the femoral canal descends vertically till the saphenous opening. Due to the attachment of the superficial fascia to the lower part of the circumference of the saphenous opening, the hernial sac is directed forwards, pushing the cribriform fascia. Then it curves upwards towards the inguinal ligament. It is confined to the inelastic walls of the femoral canal. The hernia is narrow, but once it escapes through the saphenous opening into loose areolar tissue of the groin, it extends considerably. A fully distended femoral hernia assumes the shape of a retort and its bulbous extremity may be above the inguinal ligament. By the time the contents pushed so tortuous a path, they are irreducible and apt to strangulate. Clinical features. Before the age of 15 years, femoral hernia is rare. Above 20 years, femoral hernia is common. Right-sided femoral hernia is more in occurrence than comes the left and bilateral. The symptoms of femoral hernia are less pronounced than the inguinal hernia. Small femoral hernia may be unnoticed for many years and then may strangulate. Pain. Rarely femoral hernia may cause throbbing pain due to adhesions to the greater omentum. Swelling. Main symptom is the presence of swelling. Large swelling is a rare occurrence. Types. Hydrocele of femoral hernial sac. The neck of the plugged with the omentum or by adhesions, and hydrocele of the hernial sac results. Logier femoral hernia. It is a hernia through a gap in the lacunar ligament. Gimbernat's ligament. The diagnosis is based on the unusual medial position of a small femoral hernial sac. Mostly it is strangulated. Nodus femoral hernia. It is rare occur in congenital dislocation of the hip causing a lateral displacement of the psoas muscle. The hernia lies behind the femoral vessels. Cloquet's hernia. Here the sac lies under the fascia covering the pectineus muscle. It may coexist with the normal femoral sac. Strangulated femoral hernia. Narrow, unyielding femoral ring may cause strangulation and even gangrene. Frequent occurrence of Richter's hernia may also be the cause. Inguinal hernia, sapina varex, enlarged femoral lymph nodes, lipoma, femoral aneurysm, psoas abscess, distended psoas bursa, a rupture of the abductor longus with hematoma or to be differentiated from femoral hernia. Treatment of femoral hernia. Due to risk of the strangulation, herniorrhaphy operation must be performed immediately it is diagnosed, is the only reply. Operative treatment. There are three types of operations possible: low operation, high operation and inguinal operation. In any case, the bladder is emptied before commencing the operation. Low operation, Lockwood operation. Groin crease incision is made and the sac is dissected out below the inguinal ligament. All the anatomical layers which cover the sac are peeled off. After freeing the adherent momentum, the neck of the sac is pulled down, ligated as high as possible and allowed to retract through the femoral canal. The canal is closed by suturing the inguinal ligament to the iliopectineal line using three unabsorbable sutures with monofilament nylon. High operation, McEvdy's operation. A vertical incision is made over the femoral canal and continued upwards above the inguinal ligament. Through the lower part of the incision, the sac is dissected out. Inguinal ligament and the rectus sheath are exposed through the upper part of the incision. The superficial inguinal ring is identified and an incision of an inch is made above the ring and parallel to outer border of the rectus muscle till the extraperitoneal space is formed. In this space, the hernial sac and entering the femoral canal can easily be identified by gauze dissection. If the sac is small and empty, it can be drawn upwards. If it is large, the fundus is opened below and its contents, if any, dealt with appropriately before delivering the sac upwards from its canal. The sac is then freed from the extraperitoneal tissue and its neck is ligated. A view of the iliopectineal ligament is obtained and the conjoint tendon is sutured to it with non-absorbable sutures. If a resection of intestine is required, ample room can be obtained by opening the peritoneum. If infection occurs, incisional hernia is not very unusual. Lithisens operation. The inguinal canal is opened by incision in skin and subcutaneous tissue half inch above and parallel to the medial 2/3 of the inguinal ligament. The transversalis fascia is incised to the medial side of the epigastric vessels and the opening is enlarged. The peritoneum is now displayed. The surgeon must be certain that it is peritoneum and not the bladder or a diverticulum. The peritoneum is now picked up with dissecting forceps and incise. It is now possible to ascertain if any intraperitoneal structure is entering the femoral sac. If the femoral sac is empty, hemostats are applied on the edges of the opening into the peritoneum, and by gauze dissection the sac is withdrawn from the femoral canal. An empty sac can be delivered easily. If the sac is occupied, the following procedure is followed. The Lothison's repair. The conjoint tendon is sutured to the iliopectineal line to form a shutter, protecting the external iliac vein with the forefinger. Unabsorbable sutures are passed through the perosteum and Cooper's ligament, overlying the iliopectineal line. The retractor is removed and long ends of the sutures are passed from within outwards through the conjoint tendon and tied, thus approximating the conjoint tendon to the iliopectineal line. If there is any tension, a Tanner's slide will facilitate this step. The incised external oblique is sutured. Treatment of strangulated femoral hernia. Lothison's operation is performed with some modifications. After the external oblique is exposed, the inferior margin of the wound is retracted, thereby displaying the swelling. The coverings of the sac are incised and peeled off till the sac. Dark from contained blood-stained fluid is seen. The sac is incised and fluid escapes is mopped with great care. The retractor is removed and the operation is continued above the inguinal ligament. High operation. McEvadis operation. A vertical incision is made over the femoral canal and continued upwards above the inguinal ligament through the lower part of the incision. The sac is dissected out. Inguinal ligament and the rectus sheath are exposed through the upper part of the incision. The superficial inguinal ring is identified and an incision of 1 inch is made above the ring and parallel to outer border of rectus muscle till the extraperitoneal space is found. In this space, the hernia sac entering the femoral canal can easily be identified by gauze dissection. If the sac is small and empty, it can be drawn upwards. If it is large, the fundus is opened below and its contents, if any, dealt with appropriately before delivering the sac upwards from its canal. The sac is then freed from extraperitoneal tissue and its neck is ligated. A view of the iliopectineal ligament is obtained and the conjoint tendon is sutured to it with non-absorbable sutures. If resection of intestine is required, ample room can be obtained by opening the peritoneum. If infection occurs, incisional hernia is not very unusual. Lothison's operation. The inguinal canal is opened by incision in skin and subcutaneous tissue half inch above and parallel to the medial 2/3 of the inguinal ligament. The transversalis fascia is incised to the medial side of the epigastric vessels and the opening is enlarged. The peritoneum is now displayed. The surgeon must be certain that it is peritoneum and not the bladder or the diverticulum. Once the peritoneum is opened above the inguinal ligament, one can peer with it and see what is entering the sac. With suitable retraction, Gimbernat's ligament is sought and can be evulsed by firm pressure applied by the thumb. Otherwise, by Bistoury guided by a director. This ligament is nicked in one or two places. If there is obstruction in the narrow neck of the sac, the beak of the hemostat is insinuated, and with great care the neck is sutured. The contents of the sac are delivered. Isolation and ligation of neck of the sac. The neck is freed by blunt dissection or gauze dissection till the parietal peritoneum can be seen all sides. When the extraperitoneal fat is encountered and the inferior epigastric vessels are seen on the medial side, has the dissection reached the required limit. If it is not done already, the sac is opened, finger is passed through the mouth of the sac in order to make sure that no bowel or momentum is adherent. The neck of the sac is transfixed and ligated as high as possible, and the sac is excised half inch below the ligature. The wound is closed and ended the operation. That's all about the femoral hernia, and in the next video I will discuss about some other disease. Thank you.